This is our Radiology ICM Clinical Imaging Choices lecture. We'll have the PowerPoint online, and this is the short video of it. First off, we've got objectives, and let's talk about what we're going to review here. The imaging modalities, the various choices we can make, something about their strengths and weaknesses. Ionizing radiation is a big concern. It always has been, but especially with fetal and pediatric exposure. And we give contrast agents. We can get patients to drink or to inject material, and there's some renal interactions and there's some allergic reactions, and so we need to be aware of those. And then thinking about our reporting terms, what terms we're going to use, we're going to see in a report. Well, we have 5 basic choices, and if we separate the two by ionizing radiation and non-ionizing radiation, we have X-ray, CT, and nuclear medicine, PET imaging, etc. With ionizing radiation, and you can see ultrasound and MR do not use that. Relative to cost, if we use a chest X-ray as like 1 unit, so to speak, we can see that relative scale kind of from X-ray to the chest to the abdomen to GI and abdominal studies kind of 5 times. CT, nuclear medicine, maybe 10 times, and MR maybe 15. Now these can vary a little bit, but it's generally if you want to think about it, a 1 to 10 ratio for a CT versus a plain X-ray. How about availability? Well, what's most available? Probably X-ray. The machines can be portable. They can be done bedside. They can be done in the ICU. So they're probably most available. CT has gotten very available because it's so well used in emergency imaging, so it really has to be close to emergency and really has 24-hour access. Ultrasound, that may be changing somewhat with all of our physicians carrying your pocket ultrasound with you, so we might see that ultrasound becoming almost as available or more so than X-ray. And MR and nuclear medicine are probably least available. They're more complex studies. They take longer. With nuclear medicine, you have to order a radioisotope as a specific medication to be administered, and the time schedules and the cost make those not as available. All right, so if we think about X-ray for a minute, what do we have? Well, basically we have a giant, if you want to say a light bulb, but it's a high voltage light bulb, and these electrons that are glowing around this filament get accelerated across a high voltage gradient or a high voltage gap. They strike this target. They generate these high energy photons, which are really just light photons, but they're much higher energy. And that's what the ionizing radiation, the X-ray, really is. And that X-ray, that high energy photon, travels through the person or the patient and can strike a detector, and that shadowing effect is what gives the image. And so if we look at our comparison here, we have an X-ray of a chest, and our friend here has got some pacemaker leads here, and here we have an X-ray of the abdomen. We can see the pelvis here and the spine. Here we can see the heart and the lungs. This also shows something about the relative density. In X-ray terms and reports, we'll talk about density, relative density, and from the most dense to the least dense, well, metal, you can see that's very white. That's causing the most blocking of the X-ray. Metal, and then bone, we can see the skeleton, and then the soft tissue, maybe looking here at the heart, maybe a little bit of, we're seeing maybe a little bit of the liver here, soft tissue, and then after the soft tissue we have fat and air. And fat can be somewhat hard to see, but this darker outline here, that's fat outlining the bladder, and here's some fat along these paracolic gutters out here. So fat is probably a little bit harder to see right there, and even less dense than that is air, as you can see here in the lungs. So the terms that we're going to see in reports, we're going to talk about relative density, how dense something is, and we might use terms like opacity or attenuation, how much something blocks the X-ray, the attenuation. And then if it has less attenuation or less blocking of the X-ray, we may use a term like lucency or relative lucency. So if we continue and we think about looking at our abdomen X-ray here, we know there are organs and structures in there. We can't see them very well, but we can give a patient something called contrast. In this case, it's an oral contrast, and it's outlining the stomach. This is barium. It's an inert material. It's really, I used to say it was ground up rock, but I think technically it's a metal. But it's not something that will be injected into a vascular tree because it's a particulate material, and so it would be a problem also if there was ever GI tract perforation, because now it would be all adherent to the peritoneum and it wouldn't be absorbed. But it's pretty inert. Chances of allergies to to barium are pretty much nil, and you don't have any renal toxicity issues, but it's a great GI contrast agent. Well, we can inject iodine, a liquid iodine compound. It's an iodine molecule that's attached to a complex organic molecule, and that is filtered by the blood, and it'll flow with the blood, and in this case it'll travel with blood to the kidneys and actually be filtered by the kidneys and travel out through the GU tract. But this vascular contrast, this iodine, can be used to outline the vascular tree and can show us something about physiology and function. And since it's water soluble, it wouldn't be a problem if it ever perforated into the peritoneum space, into the peritoneal space, but there can be a problem with renal toxicity in certain patients, and there are some episodes where people can have allergic responses, but generally we can manage those, and that's not a limiting factor in most patients. Okay, so if we summarize x-rays, the pros and cons available, it's very available. They can be portable units. They're very fast. Cost is pretty reasonable. It's very good for air, for chest, so we can see the lungs. We can see how well the lungs are ventilated. And bones, it's very good for looking for bones, fractures. What are the problems with that? Well, that ionizing radiation, we'll talk a little bit about that. And then if you do inject iodine, you have that issue of the contrast reaction or the contrast risk. And although we can know that we see soft tissues in there, we really don't see the soft tissues very well unless we give them contrast. So what else do we have? Well, continuing along with ionizing radiation, we have CT scans, and that's another X-ray, and it's generated, but we get data from that with the X-ray travels through the patient, and we can generate a slice of information. So instead of seeing this whole body image, we can actually get a slice, and we get this numerical information that's really based on the density of the tissue, and it's based on the density of the tissue relative to water. So water is our scale, and we have things that are denser than water and less dense than water, and how we use those numbers, we're able to generate a picture or generate an image. So when we're looking at one of these slices of data, if we have our patient lying down here, we're standing at their feet looking up to their head. Here's their right side and here's their left side. And similarly, if we look at a CT scan, we'll see the patient's right side over here and their left side over here. So we're standing at their feet looking toward their head, and we can see the spine here, and we can see the corollary of the spine here, and some of the liver over here, and some of the liver here, and we'll get into more of that. But the terms that we're going to see when we talk about CT scans, we're again talking about relative density and attenuation. That again, how much blocking of the photons, blocking of the X-ray, attenuation. And these units we'll call Hounsfield units. Those are those relative units compared to water. That's named after the fellow who invented the CT scan. So if you see a report talking about Hounsfield units, we're really talking about CT scans. And since we can inject that iodine in the blood vessels, it can flow with the blood, and we can see how the tissue responds, how the tissue is perfused, and that description of the perfusion of the tissue or the blood vessels is called enhancement. So a contrast enhanced study will typically be a study where we've given some other contrast agent. A lot of times it would be a vascular contrast agent, but we could be talking about oral contrast as well. So what can we see here? Well, here we have our abdomen X-ray again. And we've seen here, we've injected this iodinated contrast, and we're taking an X-ray, and we're seeing it outline the blood vessels going to the kidneys and the aorta, the main blood vessel in the abdomen here. But if we took a slice through the middle of the abdomen, right through that aorta, we might see the spine, and we might see something like this. So we might see this big aneurysm here, and we're seeing that contrast flowing in the center of the aneurysm right here, and this gray material out here is the clot outlining that aneurysm as well. So this would be a contrast or enhanced scan or enhanced CT scan with iodine, and so that's what that slice might be looking. That's what that slice might look like. So we can get these CT scans with iodated contrast. So there's a comparison of the two. We can also do scans of patients without IV contrast, and then we can inject the contrast and do scans very early during the exam when the contrast is all flowing through the arteries, as we're seeing the aorta here and maybe the hepatic arteries over here. And then we can wait a little bit longer and do another scan, and we might see some still in the aorta, but now perhaps we're seeing more in the portal vein. And so we can see how the liver is taking up the contrast later in the phase. So we can get non-contrast and arterial phase contrast and venous phase. So we can get some physiological information. Of course, the expense with that is we're increasing the radiation dose. So Do we need to do that on everybody? Certainly not, because that radiation dose comes with a cost, but there is information that can be obtained from those multi-phase CT scans, so to speak. So I talked about that. It's digital information, so we're going to be looking at slices. And if we look at our diagram here, so if we get slices in one plane, to tell the computer to make a slice using that data into another plane is not really that difficult. So our data is generated really from these transverse slices that cut across the long axis of the patient, but we can tell the computer to remake that, make another slice in another plane, and here we're looking at a coronal slice, as though our friend was staring here looking out at us, somewhat like a chest x-ray with the heart in the middle and the lungs on one side and the other, and maybe some liver in there. So that digital information allows us to get multiple images. We talked about giving that IV contrast, and I mentioned a little bit about renal failure. Well, there are some patients that iodinated contrast can increase renal failure particularly, and it can cause an increase in their creatinine, indicating the decrease in the renal function, and they even have a term for that, contrast nephropathy, after administration of iodinated contrast, and that can occur in people. It's defined by a 25% increase in creatinine, or as you can see, another increase in the absolute level. And what are those risk factors? Well, the risk factors are things you might think about. If it's going to cause some renal problems, maybe people who have chronic renal disease are at greater risk, and that's clearly the case. And diabetes, which is really a renal disease, is also, you can see that. And who else we're talking about? Well, people with heart disease. They're having poor cardiac function, so heart failure, age, and then here we're seeing decreased volume, decreased blood pressure, and those things could be affected because now the kidney is going to have to filter that more concentrated, and then the overall volume of contrast. So though those factors can all come into play, and what can we do to minimize the risk? Well, one thing we can do, alternative imaging. Maybe we can do a study where we don't have to use iodinated contrast. And then the other best things are really hydration. You try to keep the patient well hydrated so that iodinated contrast, if you want to think about it, is diluted and filters out a lot quicker. There's also some other ideas about using bicarbonate to alkalize the urine, and that might limit some of the acid effect and some of the free radicals. And then there's another drug called N-acetylcysteine, which is a acetyl substitution of cysteine, and that again has some antioxidant effect. But these have to do with, again, that acid and that antioxidant effect. But really the hallmark of that is really hydration and really alternative imaging, if you can come up with it. All right, so if we think back again about CT scans, the pros: availability, fast, great for emergency imaging. You get to survey the whole body, and you really get pretty good soft tissue resolution. A lot better than X-ray, maybe not the best, but a lot better. What are the cons? That radiation is an issue again. IV contrast, we talked about, those are similar to X-ray itself, but then the cost. CT scans just cost more, but here's our friend here. He's having his scan done. So if we continue on thinking more about our ionizing radiation, we talked about nuclear medicine. Well, what is that? Well, in that case, we've injected a drug that has a radioactive tag on the drug, and that drug is called a radiopharmaceutical, and because of that drug is handled physiologically in the body, and depending on how that drug is designed, it may go to a specific system, whereas here we're seeing it outlining the bone, and that radioactive tag shows up. So in this case, we can see somewhat of the function of the body based on that radioactive tag traveling with that radiopharmaceutical. So it has that advantage of some organ specificity. We can design the drug to go to a specific organ. It does have that radiation effect. Don't have as great a detail with anatomy, but let's just sort of see. So here's another example, something called a PET scan, FDG PET. That's fluorodeoxyglucose. It's basically just a radioactive glucose, and it will travel with the regular glucose, with the glucose that goes to metabolic sites, and so we can see these areas in the body right here. It might be hard to tell, but from knowing there's a nodule in the lungs right there, we can tell that excess metabolism at that nodule can be a pretty worrisome finding that might be a malignancy, because see, that's got much higher metabolism than the remainder of the lung, and malignancies certainly can have higher turnover with all that growth going on there. PET stands for positron emission tomography, but it's a radioactive glucose scan which shows you something of metabolic activity, and that metabolic activity can be somewhat of a surrogate for a predictor of malignancy. Well, what about that radiation exposure with these radioisotopes? Well, that radiation dose that we're going to get really has to do with the physical and the biological half-life. Half-life is a term you had heard in physics, and it describes the decay of a particle, where how long does it take for half of the amount to be gone, and then another half and another half. So physical compounds that are radioactive have a physical half-life, but also depending on how quickly something is excreted by the body, there's a biological half-life. So here we can see this is our renal scan, and this radioactive isotope is being filtered through the kidneys. Here it is in the bladder. So certainly you could see that if it goes out of the bladder pretty quickly, and if you urinate it out, you're going to get rid of that radiation dose independent of the physical half-life. So the combined half-life really depends on the physical half-life and the biological half-life. Here we're seeing some of it. It's going through the liver. It's going out in the biliary tree into the GI tract. So it's going to go on out through the colon, and so those two determine the overall exposure. All right, so what are the pros and cons? Nuclear medicine, well, you get that physiology and some metabolism, and we can quantify it because it's radioactive counts. We can count how much activity went someplace. I guess I showed you this nuclear scan with these kidneys, and so here we've actually graphed that activity. So we can draw a graph and compare the right side and the left side and get some of that information. So it is quantifiable. It is tissue specific. But what about the cons? Well, again, that radiation, time and motion, it's slower. If the patient moves, we can lose a lot of detail, and we don't get that great anatomy. The cost is pretty high. What terms are you going to see when you see a nuclear medicine report? Well, you might see something talking about intensity or activity would be the terms. We're really not going to use that term density because this is really how much radioactive isotope is actually in the organ at the time. So radiation can give you a lot of headaches like our friends here. We talked a little bit about X-ray, CT, and nuclear medicine, so let's just try to think a little bit about what is the problem with this ionizing radiation. And if we think about it, the problem is that ionizing radiation can break bonds, and that breaking bonds can lead to a DNA break. And so that DNA break can, of course, be lethal to the cell, which is really the way radiation therapy for cancer works. But that can also increase cancer risk because that can lead to genetic defects or mutations that don't get repaired, and really could be an increase in fetal genetic risk. But I think it's that increased cancer risk is the one that we tend to talk about. What is the problem with that? Well, it's got a 10 to 20 year latent period, so it's not something that happens instantly. And so if it's got a 10 to 20 year latent period, that would give you a pretty good indication that it's not much of an issue in an older patient, but it would be a much bigger issue in a younger patient because they've got more life to live, and that latent period can more readily come into effect. So when we talk about radiation risk, we talk about deterministic effects and stochastic effects. Deterministic effects really just depends on dose. If you get a certain amount of dose, you're going to have a certain effect. Stochastic effects have to do with the probability of events, and that has to do with the cancer induction, and there's a probability. It's not an all or none phenomenon. The report terms can be very confusing. Generally, sieverts are the terms that are used to describe radiation dose and radiation exposure now, but there are other terms you might hear, grays and rims and rads, and that really gets pretty complicated. I think we'll just sort of leave that for right now. But in terms of deterministic effects, those are dose related, and fortunately we don't really see those in what we're doing with diagnostic studies. There are some very rare events where someone can get a skin erythema from a procedure. This person had a heart catheterization and had a lot of radiation to the skin, but these other ones, radiation sickness, has to do really with radiation accidents, and those have to do with things like bone marrow and GI tract. So really the deterministic effects are very high dose effects. What we worry more about is a stochastic, which is a probability effect. And this is really all based on the Hiroshima bomb survivors because there was an excess cancer risk in those survivors. Again, it wasn't seen until 10 to 20 years later, and trying to extrapolate that to what does that mean for diagnostic radiology can be a bit of a problem. But I think generally in that range of 50 to 100 millisievert exposure can increase the risk in humans, is what was found from that data. And so what does that mean? Well, the New England Journal was concerned about this and put an article about CT radiation exposure. And part of that is because this background radiation that we all get from just being alive is a certain number of millisieverts in a year. So you might get 3 millisieverts in a year. and some of that for a population could have been medical. So right now, at least in the United States, there's a lot more medical radiation to the population, and so those millisieverts have gone up to maybe 6 a year. So, that's not a lot, but if we go back and think about 50 to 100 millisieverts cause some increased risk in cancer survivors, do we need to worry about that? And so how do we get a handle on that? Well, it's a little bit hard to think about, but as we talked about background radiation, where somewhere you might be getting 3 to 6 millisieverts a year for background radiation, so we could think of a chest x-ray. One chest x-ray is maybe about 1/100th of that. So you'd get that with one chest x-ray, maybe the equivalent 1/100th of a unit of background radiation for the year. So that's really not that much to worry about. CT scans on the other side of that can be substantially more, and again, it's not a lot to worry about for if you're getting one CT scan or two or perhaps, but it is a multiple or at least a unit of background radiation. And so if you plot a graph of these Hiroshima bomb survivors, there's a wide spread here in the data, and if you plot how much 4 full body CT scans were versus 1 full body CT scan, statistically you're sitting on that curve of those Hiroshima survivors. So that's why that concern about overall radiation dose gets there. And so while there is a risk, it's a statistical risk that's based on population studies, and there's really never been anybody who's been able to prove that a CT scan caused a cancer in a person, and that's because a lot of reasons is that it's extrapolating the dose from these higher doses down to much lower doses, and then the sample size, because the background cancer risk is really hard to tease that out. So I think if we think about that, though, when you have that radiation exposure, you've got about a 10 to 20 year latent period before there's any effect, and then that effect does grow over time, and so that's that difference in the normal cancer rate and then that additional cancer rate due to radiation. So that's what we're concerned about. Now, if you look at that on a graph, really that curve is not shifted a huge amount. Now here what we're seeing here is the function of the background or the normal cancer rate, and then this other one would be the theoretical shifted rate, and this would be for a person getting radiated at age 45 and following up to age 70 with this 100 millisievert dose. So this is not a huge shift because there really is a background rate of cancer, so it's a little bit hard to tease that out, but it is something to think about. And so I've got this website for you here if you want to get some more data about physics. I think that's why most of y'all went to med school, so we can skip over that. So that covers our ionizing radiation choices. If we think about the non-ionizing radiation, the point about that is there's no fetal risk here. So that's where we don't have that ionizing radiation. So that would be ultrasound and MR. Since we go to the University of South Carolina School of Medicine, we know a tremendous amount about ultrasound already, so we don't need to go over a lot of that. But, and again, no ionizing radiation, it's all reflected sound. So we can see things like gallstones here layering in the gallbladder, and we're comparing that with what it might look like on an x-ray from an operative study, where here's some contrast has been injected, and these lucencies we're talking about here, or filling defects on the x-ray, the terms we might see in an ultrasound report might be areas of echogenicity, and we might talk about things being hyper or hypoechoic, and sonolucency might be a term if describing perhaps more of this fluid fill structure. And we can talk about shadowing that blockage, but we've heard those terms, and we know that ultrasound is very good for obstetric screening as well as vascular screening. And so the pros of that are the non-ionizing radiation, and it's not motion limited. I mean, it's you can follow motion, and it's portable, and it's the cost is pretty reasonable. I mean, it's good for pediatrics and obstetrics patients, and so motion limited. I mean, the kid can be running around the room, and you can be chasing him around with the ultrasound, and I guess you're not really having any limitation on that unless he trips or you trip. But what are the cons? Well, it's operator dependent, and you've still got to create the picture yourself. And our friends here are a couple of our students. They're kind of studying at that, trying to figure out what they're looking at. And you've got a limited field of view. It's a smaller field of view than you get with a CT scan. And then air can cause some problems with limitation. We don't really see the lungs very well, but we do see fluid fill structure. All right, so let's go on to magnetic resonance here. We've got our last one to think about. It can be some complex physics involved in that. It regards, it has to do with hydrogen protons and magnetic fields, and beaming a radio frequency pulse in there, and then we create an image. We don't have that ionizing radiation. Here's our friend here. The RF pulse is coming in. His protons are all aligned in that magnetic field prior to that RF pulse, and when they get disturbed by that RF energy, they resonate out a signal, and that signal is what we use to create an image. So the reporting terms you may hear will be about signal. There's an area of increased signal or increased signal intensity, and it describe an area that has a bright MR signal. And again, because we can give contrast with the MR scan, we can get some contrast enhanced effect. Here we're just comparing a lumbar spine plain x-ray on this side and a lumbar spine MR here, and so we can see how we can see that disc tissue a lot better. We can see the little bulging disc sticking out there. Here we know there's disc material there and there, but we really can't see it. We know that's there. Here we can see some of that cerebral spinal fluid. Here we can see a couple of those little nerve roots, and so we get much better soft tissue detail. As I mentioned, we can inject some contrast with the MR scan, and here we've injected some gadolinium, which is a contrast agent, and so it's outlining those blood vessels, and so we can get an arteriogram-like effect, and we can see how well tissues perfuse as well with that, and we're comparing that gadolinium MR scan with this standard arteriogram where this catheter is actually in the artery injecting it, so we can get a pretty good picture there. But what are the problems with gadolinium? Well, it is a contrast agent, and it can have some toxicity in patients as well, and it can have toxicity in patients with renal failure. Now, in this case, it's not that the gadolinium makes the renal failure worse. It's the problem that the patients with renal failure do not clear this gadolinium as rapidly, and so because it stays in their body longer, it can disassociate, and it can have some toxic effects in the tissues, and it can lead to a very peculiar reaction, a systemic fibrotic reaction, which can be fatal. And so this term nephrogenic systemic fibrosis is one you'll hear referred to with gadolinium, and if you search gadolinium toxicity, you'll get all the attorneys that want to get your case for you. And fortunately, since it's now being limited as a contrast agent in patients with renal failure, pretty much this entity has gone away, but it is something to be aware of. So what are the pros with magnetic resonance? Well, great soft tissue. You saw how the disc spaces in the nerves were there. We can see CNS anatomy and musculoskeletal and vascular. We can see that very well. How about the no ionizing radiation and really minimal allergy? What are the cons? Well, the cost. It's cost and availability. It's not really something that's immediately available. Motion. These patients have to hold still. So, trying to get someone to hold still who's very sick can be a problem. And then the ICU, the very sick patients and claustrophobic patients, these MR scanners are pretty confining places and really not a good place for an ICU or a claustrophobic patient. That RF energy that we're pulsing in there, it can have some effects on pacemakers. So generally it's been that patients with pacemakers are really not or should not be in an MR scanner because of the effect that RF energy can have on that pacemaker. And because of those strong magnetic fields, there can be some problems with patients who have any kind of little metal particles in their eye. It can cause some trauma as that metal moves around in the eye. And there are these horror stories of sometimes an oxygen cylinder got sucked into an MR scanner and there was somebody in it. So aneurysm clips are another thing that theoretically they can be moved by the strength of the magnetic field. So there are some effects that are peculiar to that magnetic field strength. And then that other one we mentioned about that nephrogenic systemic fibrosis and that gadolinium toxicity. So if we summarize everything, I think if we talk about cost, X-ray probably comes out ahead. Being portable, probably ultrasound, maybe X-ray as well. Safety, I guess we'd probably say ultrasound. How about for emergency imaging? Well, that's probably where CT really comes into effect. How about the radiation risk? Well, the other studies, nuclear medicine and X-ray have radiation, but I think CT has a higher relative dose, and CT is being used fairly commonly, so that's probably where the radiation risk is the concern. The renal risk, iodinated contrast, especially patients who have some sort of renal compromise that can make their renal failure worse. We've used that term contrast nephropathy. And what about that NSF, or nephrogenic systemic fibrosis? A peculiar risk, but it's related to gadolinium And patients, again, with renal failure, not causing their kidneys worsening, but the patients with renal failure can have a response to that gadolinium. Allergic risk, that's something that comes up occasionally, more with iodine. And so that kind of gives us our summary. So if we think about that, I hope you haven't fallen asleep while you've been listening to this, but it's a shortened view and the PowerPoint's online. Thank you.